Oh,
It's official.
it's official.
All right, welcome everybody. Thank you for joining us for April's Spotlight Series. I'm going to hand it off to Ben for a quick introduction.
Thank you, Priya. Well, appreciate everyone taking the time to join us today for this April Spotlight. We're going to be talking about strength beyond painkillers, using PT as a first line of defense against back pain. My name is Ben Gordon. I'll be co-presenting with Tyler Lusignan. We're both PTs here at NICE, and yeah, let's dive in. So the tide is still shifting when it comes to using PT as a first line of defense against back pain. I don't think this is the case at NICE. I think we have a very special group of people here and who are evidence-based, but the reality is that the rest of the medical world is still kind of behind. And as a result, our patients suffer, and we often see that they come to us using things like painkillers, these kind of quick solutions to address things like back pain. There are now mountains of research demonstrating that PT it should be the first line of defense against back pain and other types of chronic pain. I didn't realize I'm in control here. Okay. There is a catch though, which is we have all this research, but it takes a really long time for this research to be implemented into the clinic. Now, this is a very broad number, but there's been a number that says it takes about 17 years for a research study to reach the clinic. Now, take that with a grain of salt. The point is, there's huge delays in implementation. And this can cause some serious issues, especially when it comes to things like back pain and managing back pain, because it's complex. And specifically with regards to back pain, it has led to crises like the opioid crisis, which we'll talk about in a sec. But we're real lucky at NICE to have this integrated care model because we can really help minimize these delays. And just to put this delay in perspective, a study that came out in 2007 indicating that PT should be used as a first line of defense would probably just be implemented within the past few years, if not this year, which is kind of mind-boggling. And there's a whole lot of reasons for that. It's not just because people don't know it's the right solution, but it's very complex. It takes a while. So yeah, the opioid crisis, we're probably all familiar with this. It is the result of the over-administration of opioids and other medications, and it's led to a huge dependence problem and also a huge kind of dependence on quick and fast solutions. I think that's another unintended consequence. At best, these opioid-centric solutions, they just mask patients' physical problems. They delay, they impede recovery, and at their worst, right, they're dangerous. They're just outright dangerous and they're deadly. And the numbers unfortunately speak to this because it's kind of tragic what has happened to our country and obviously other countries as well. But in the US, the deaths have quadrupled over the past 15 years due to opioids. And in just plucking a year out of the research, 2018 alone, $180 billion in costs just to manage these conditions. That was due to mortality costs, due to healthcare costs, productivity costs, criminal justice costs, like the loss of life, in addition to the economic issues, just staggering. And the CDC director said in 2016, we know of no other medication routinely used for a non-fatal condition that kills patients so frequently. And I know we don't really push these at NICE, but there are still these meds being pushed on people in the world, in our country. And yeah, we have to deal with the ramifications. So why are painkillers the wrong approach? Painkillers act under the assumption that pain is only caused by an external stimulus. And while this can actually, obviously be true, right? If you have some type of trauma, a pain signal will be sent up into your nervous system. But that's only half of the story. There's an entire top-down process that happens as well. And that involves psychological implications, social, understanding your social situations, how pain is tied to your identity. It gets very complex. And these top-down influences can help explain why someone can have pain without any physical damage. And unfortunately, this is relatively new in the medical world, kind of understanding pain in this way. And this is kind of what we're fighting against. A really good example of this top-down process, and this is an extreme example, is this story of a guy who stepped on a nail and the nail went through his boot. He was rushed to the hospital and was in so much pain in the hospital that they had to sedate him, only to find out that the nail had passed through the space between his toes, hadn't even gone through his feet. And in interviews afterwards, the guy explained it was still one of the most painful experiences he'd ever had. And I think this demonstrates that the pain can happen from non-physical stimuli. In other words, top-down influences. And such is the case, like pain is complex and therefore should require complex care and complex solutions. So we really are trying to move away from this biomedical model towards a more biopsychosocial one, because your social circumstances, your psychological, your mindset, all those situations can really contribute to the amplification of pain, and in some cases can cause even more pain. So imagine this real quick, just to kind of paint this picture. All right, you're an avid pickleball player. It's a huge part of your identity. And suddenly you have back pain. Like you just wake up with back pain, it's whatever. And you suddenly over the next week just start playing less and less. Your friends are all at the pickleball courts. It's a great way to connect with your spouse. You have a trip planned. Do you think your back pain is going to be amplified? I think the answer is a resounding yes. And a part of your identity is probably being ripped away from you. So these are things that we really want to consider instead of just focusing on the physical aspects of pain, and is a huge reason why there's the big overlap between mental health and PT. We're all of us, including the medical team, mental health, PT, our job is to improve agency, right? The ability to help people to control their future states of being, to control their health. And where mental health can really come in and help is with applying and assessing certain coping strategies, and also helping with management of conditions that may actually make pain worse because of these top-down mechanisms. Things like depression, anxiety, catastrophizing, fear avoidance beliefs. So yeah, our understanding of pain is really kind of transformed over the past decade, and I'd probably say longer than that. And yeah, we're really, really fortunate and nice to have this integrated care model to be able to create these more complex but targeted and personalized solutions. So with that, I'll pass it off to Tyler to talk about the role of PT.
Yeah, thank you, Ben, and appreciate you kind of showing us what the problem is, but I'm hoping to take the second half of today's talk and show why PT First is a viable solution to start to chip away at this crisis. And so I think it's important to start with who is more likely to develop this chronic pain. We hear all the time about, oh, I'm paying for it for being so active in my younger days, or, I just got this from my mom and my dad, like I just had a bad back. And when we look at the research, it actually shows that self-confidence and the ability to cope with disability are the most highly correlated with some of these long-term results. And so that really just ties in nicely what Ben was talking about, of us being biopsychosocial individuals and not just made up of our muscles, joints, nerves, and discs, but more how are we actually thinking about our pain and how we're able to cope with all the ramifications that come with it. So why PT First? Why do we feel like this is a more viable solution in the prevention of chronic pain? And so PTs are going to evaluate the individual for risk factors for pain to help prevent future pain issues. And some of these include disease history. Obviously, we want to look at things like diabetes and neurological conditions and things like that, because we know that that can play a part in their pain experience. Some of their cognitive and psychological factors play a big part, like we were alluding to. Their beliefs on, do they actually think they're going to get better, or have they always been surrounded by people with pain, and do they think that they are, destined for surgery? That's going to play a big part in their thoughts and how they are presenting with their pain experience. And then also just a sedentary lifestyle. In addition to the opioid crisis, we are in the midst of an obesity one as well. More and more people are not hitting the ACSM guidelines for physical activity. And we know that a sedentary lifestyle is highly correlated with developing chronic pain. And so once we identify some of those patient pain risk factors, we want to make sure that we are establishing a goal and a plan of care that the patient feels motivated by and is individualized to them. So our treatment program can combine any and all of these lists with these techniques. So just kind of touch on the first one here, like therapeutic exercise. Let's say we do an evaluation on an older gentleman or lady, and they have a goal of picking up their grandbaby without any back or shoulder pain. Well, therapeutic exercise might start with some resistance bands or light dumbbells and things like that, but to truly tie it into their goals, we want to transition that plan of care into actually picking up their grandbaby for reps and like make it part of their plan so they can really see how it's tying in, and they're not just doing shoulder external rotation for 12 weeks. Some people might need manual therapy, and that's certainly one of the techniques that is in our toolbox. We know that humans crave touch, and that can be a good pain reset. So that's certainly something that we can rely on for some short-term pain relief. Just educating the patient on what's going on, and giving them an accurate prognosis, ensuring that, hey, this isn't a red flag, life-threatening situation, can really give some people peace of mind and not go into Google Doc and think that next thing they're going to have to do is amputate their arm off, because we know the WebMDs of the world can get a little drastic. And we know some really big needle movers in pain are stress and sleep. And so obviously we want to stay within our scope, but given some guidelines on just some generic stress management techniques, breathing, journaling, mindfulness can really play a part in looking at that person as a whole, and touching on some sleep hygiene tips. Some people don't even realize what they're doing in the evening is really affecting their quality and quantity of sleep. And that is a pretty low-hanging fruit in the pain world of addressing how well someone is sleeping. And then finally, making that connection and that pain neuroscience education of pain and damage are not always synonymous, and they're not a one-to-one correlation. An analogy I like to give with this a lot of the times, just to kind of put in y'all's toolbox, is the mystery bruise. You're running and gunning throughout your day. 2 days later, you look down and there's a bruise, and you're like, well, where the heck did that come from? Well, physical damage happened there, but because you weren't paying any cognitive attention or giving it any weight in your mind, there was no pain association with what is an obvious evidence of damage occurring. And then on the other end of the spectrum, the paper cut, a tiny little bit of damage on the tip of your finger, but pain is really amplified. And so making those kind of real life connections with our patients can be really beneficial and uplifting for them, knowing that they can have pain without damage. So in line with PT First, we kind of wanted to make the imaging note here that X-rays, CT scans, and MRIs are not helpful, and in some cases can be detrimental to the patient's prognosis. And I'm speaking in general terms here, but once we send someone out of our office or virtual space, we can't control what other people are telling the patients. And I'm sure we've all heard, oh, my doctor said I have the worst back that they've ever seen, or my knees look like an 80-year-old's. And first of all, that's not helpful at all for anybody to be told that. But we also, more importantly, know that there are people walking around right now with herniated disc and rotator cuff tears and degenerative changes in their knees with absolutely zero pain. And so there's a time and place for imaging, but we think a more thorough approach would be a detailed, subjective history and movement screen, and ensure that, of course, you're appropriate for PT services, but then really start to work to identify those factors that could be contributing to their back pain. and then develop a personalized treatment plan to address those clinical presentation limitations and their individualized goals. So I really like this graphic because it kind of contrasts the two different approaches that we're talking here. So the kind of outdated approach, we'll call it, not only is one that takes up a lot more time and finance, but also finances. So let's say an individual develops back pain. They have to wait a couple weeks to get into their primary care visit. Then that primary care physician says, something's not adding up. We got to send you to a specialist. Then the specialist's like, oh, let's take a couple more weeks and get you into your MRI. So here's, anywhere from 2 to 12 weeks have surpassed as this person is shuffled through the healthcare system just to get an MRI for them to be like, okay, yeah, let's get you to physical therapy. As opposed to, hey, I have back pain, let me go see my PT. If there are some red flags, something's not adding up, let me send you to the specialist or go get an image. But more times than not, hey, this is definitely something we can treat. Let's get you moving and rolling and feeling better much quicker than going through this kind of outdated approach. And so PT First at NICE is already leaps and bounds ahead of the game compared to the norm. With the new addition of direct access, we are able to now really cast a wide net for those individuals that know that they probably should be seeking out some care, but have convinced themselves otherwise that I just don't have the time to allocate for that. And so self-scheduling with visits from your home or work for convenience is really going to start to chip away at these people that maybe would put their own health on the back burner or get lost in the healthcare system. Ultimately, another thing that the research shows is building an internal locus of control over their health is the best prognosis for them to deal with this chronic back pain. And so while we stand firm that virtual care is really, really a great option, most importantly, it builds that locus of control for their individuals because they know that they're getting better on their own. They're in the driver's seat. We're in the passenger seat guiding them along the way, rather than them tying their progress through being at the clinic. And of course, we're always monitoring and doing re-evals. And if adequate progress is not being made, we can assist in transferring care, whether that be to another NICE provider, or if they need in-person care, we certainly can assist in that. And coordinating care, like Ben said earlier, with mental health to ensure that they're being treated in that biopsychosocial manner. So we wanted to round it out with kind of a real life scenario to kind of paint a picture of what PT First looks like. So let's take Jean, a 73-year-old woman taking Percocets daily for several years. The pills can offer sometimes immediate but less than satisfactory pain relief. She comes into PT, whether it be in the clinic or virtual, with a goal of discontinuing the pain pills. She offers that the granddaughter is a supportive caregiver who can be counted on to assist in her plan of care. Upon the examination, PT determines she has generalized weakness, poor balance, poor fitness, and fair overall health, but difficulties performing her ADLs. She's developed some fear-avoidant behaviors, and she expresses a great deal of stress associated with her longstanding condition. So PT First focus of care would determine, okay, we need an integrated plan of care. And so what would that look like? Maybe we combine PT interventions with fitness, such as yoga and behavioral health strategies. Maybe we can help identify some community resources at the local senior center, develop a comprehensive pain treatment of how effectively Jean's current use of pain medication addresses her chronic conditions, transitioning into self-management with steps including managing her chronic conditions to lessen her periods of active pain, educating her about the pain, building strength, balance, and endurance to improve her overall health, and then, of course, involving her granddaughter in the treatment plan in order to promote a smooth transition from skilled therapy. And ideal outcomes look like Jean no longer has to take her pain medication routinely. She would limit her use to the occasional situation in which her pain is exacerbated, and she can oftentimes manage her condition by going to the gym, group yoga classes, and enjoying time with her granddaughter, which is mutually beneficial because she's now seeing her grandma healthier and more active. And I'm going to send it back to Ben to close us out.
Thanks, Tyler. Well, I think a big takeaway here should be that, we still have to actively combat the opioid crisis that is still very alive and well. And PT First is obviously the way we think we can do that here at NICE. It is both logistically and financially the best route. And our Practice Act requires that we refer out when red flags are present, even if they're not appropriate for a PT. So I guess the final note is that we really want to continue leveraging the integrated care we have at NICE. We are so lucky to have such a network of different expertise and just knowledge, and we're going to get patients to the right place at the right time quicker. And I think we should continue to leverage that with the patient's health front of mind. So really appreciate everyone taking the time out of their day to be here and join us in this presentation. And we're happy to take any questions right now. Tyler, I have a few questions for you to kick something off, but I'll wait like, I don't know, 5-ish seconds. If anyone has any questions, you can post in the chat as well. But yeah, thanks for being here.
Yeah, thank you so much.
So Tyler, first off, quick question for you.
Yep.
What are some big myths that you think would be valuable to dispel with regards to back pain? Pretty massive question.
Okay. I think a lot of people have the misconception that there's like inherently bad movements for the back. And the way I like to describe it is like there truly isn't any bad movements. It's just the ones that your body's not prepared for. So you hear all the time that, oh, I'm not going to squat, or I'm not going to deadlift, or I can't do that because, I'm going to throw my back out. Well, they're really, first of all, I want to just be promoting physical activity, and people are making more barriers for themselves than they need to be. Like dispelling that can hopefully open some doors to where people feel more confident that, hey, you don't have to go straight into deadlifting. Maybe we can do some glute bridges, and then that transitions into some hip hinges, and then we can throw some weights in your hand. And so that's kind of how you gradually expose the body to those demands to where you eventually can handle deadlifts, just to use an example. But deadlifts in themselves aren't inherently bad or unsafe. It's just how do you expose your body to that to not shock the system, if you will.
Yeah, I definitely see that too. I think a big part of it is a lot of people think, kind of going back to this biomedical model, that something's wrong in their back. How do you navigate when someone comes to you with like, fear of slipping a disc or something like that, which is a very reasonable concern I think a lot of people have.
Yeah. I think I usually kind of bring up two main points in those moments, because typically people have kind of blamed their back pain on a bad L4, L5. Like we've all heard that story. I make it a point to really reiterate that just because you've been at one point diagnosed with a herniated disc doesn't mean that's your new norm and that you're stuck with a herniated disc. I think a lot of times people don't realize that herniated disc can resolve on their own. The body's very good at healing itself, and we know from the research that actually the more pronounced the herniation is, the more evident that disc can actually get back into its native state. And then I kind of like to do like some motivational interviewing techniques of, okay, like I certainly get what you're saying, and that that makes sense. But if I were to pose a question back to you, you talked about, 10 years of on again, off again pain. What do you think is happening at that L4, L5 when you don't have any pain? And that question kind of really gets the wheels spinning for them, because they don't have a good answer. quite honestly.
Yeah. I
And
also,
so,
yeah,
yeah,
Hey, Tyler and Ben, can I ask you a
Yeah.
question? So here's my myth that I have difficulty overcoming. I don't have the time to do this. So oftentimes, obviously, patients come to us as providers because they just want a pill, just like everything else, right? I just had this happen yesterday. Ongoing back pain, the guy's in his 60s. Have you ever done PT? No, I don't have time for that. Just give me my medicine, let me move on. So I said, you're just going to continue to have trouble unless you give PT an opportunity. And of course, it's virtual here, so that's like super easy. I can do all the selling points, but from a PT standpoint, and honestly, let's say I've never done PT. I don't know how much time this takes. Is it could it be a one and done? I just told him, have that first visit and see how it goes and see if it's worth your while. If you can then get the time in your life to do this.
I would take the same exact approach, Denise. I think just having that one visit, because there's no, you're not tied to us at NICE, right? It's a pretty low lift to be able to talk to a PT on your phone. So I love that approach. I think just having them talk to us is probably the best selling point, and they don't have to continue with us. So I think I would probably go that approach. And I think in terms of just changing one's behavior, that's how we get people to start doing their exercises. We just start with the next best thing for them to do versus kind of like thinking about the whole plan. So I think that's a great approach.
Yeah, and
Yeah.
to your point, like I think that's where I love that you said that you and mental health are closely tied, because I think there's a lot of mental health too that comes into play.
Absolutely.
Definitely.
Yeah, it's not this is not an easy topic to traverse with people. The beliefs are so strongly held, and we are just fighting that every day. So it's not easy.
Mhm.
Thank you everyone for joining. Ben and Tyler, well done. That was really excellent. I mean, and there's no bias there. That was really excellent. I will upload this recording to Loop, and if you have any questions, feel free to message us, tag us at PT in provider chat. All right.
Thank you.
Everybody.
Thank you.